Adam. I work at the University of Missouri, Columbia. Today, I would like to talk to you about tools to engage Muslim refugee youth in mental health care. I have no disclosure. My objectives for today is to understand the mental health needs of Muslim refugee youth.
Dr. Adam, would you like to share your screen with your presentation up there?
You cannot see it?
No, you'll have to click that little share screen button on your Zoom.
Okay.
It should be sort of at the bottom.
Could you, I don't know, could you share the screen from your side? I cannot find it anymore. If you can, or I'll keep trying. Yeah, I found it.
Okay.
Okay. Is it showing now?
Not just yet.
Okay, is that here?
So actually what we can do is while you and me figure this out, we can move on to our next presenter.
Okay.
If you're okay with that. Merve, would you mind starting the presentation, and then me and Dr. Adam will work out the issue so that we can have her ready. Would that be okay?
Sure.
Perfect.
Should I share my screen?
Yes, please, go for it.
Okay. I think everybody can see it now. Okay, can you see my presentation?
Yes.
Okay. Hello, everyone, and thanks for being here, listening to us. So my research was about the perceptions about Muslim refugees in the US, and I conducted a latent class analysis with a huge public data set and tried to understand the latent classes about outgroup members, including Muslims and refugees in the US. So I will give some brief background information. As you're all aware, the number of refugees across the world is increasing rapidly, and also Islamophobia has the same trend. So that's why this flow and perception usually results in negative attitudes and hostility towards Muslims and refugees, because they started to become the outgroup and perceived as such, especially in the US. So this is a globally prevalent trend, and this also creates a social exclusion, probably because of being perceived as a social, economic, or security threat. And that's why we conducted this study, and this was one of my qualifying papers for my doctoral studies, by the way. The goal of this paper was to understand Americans' perceptions about outgroups and how they are related to anti-refugee and anti-Muslim sentiment. And we used a data-driven approach to understand this issue. And we used latent class analyses in R, and we tried to determine whether there were any latent classes related to outgroup attitudes in the US. And our aim was to understand the complex issue and eventually help reduce prejudice and intergroup conflict and ameliorate negative attitudes, especially towards Syrian refugees, because we had a specific item related to Syrian refugees, and provide them with a stable social support system, because Syrian refugees consist of the largest number of refugees in the world. It's almost 1/3 of all refugee population right now. And in the present study, we try to understand the attitudes of US voters, as I mentioned earlier, and their perceptions towards Syrians and Muslim refugees, as well as other outgroup members, such as immigrants and people of color. And this study was especially important because the data set that I used was collected right before and after the 2016 elections. And this year was a big start of a sharp reversal in the immigrant and refugee policies in the US, as you all know, because of the Trump administration. So that's why we used the ANIS data set, which collected data 2 months before and after the elections. And we were specifically interested in exploring the possibility that like attitudes are not binary, like pro or against refugees or outgroup members. And there are a lot of other like nuanced and varied perceptions about outgroup members. So that's why we expanded our investigation to examine attitudes toward immigrants and people of color to understand different latent classes among Americans and work on the issue accordingly, because when you understand the issue as like black and white, it's hard to understand like what's in between. So we tried to determine like the gray areas about the perceptions about outgroup members. So I will give some literature information. So according to a survey that was conducted in 2018, almost half of Americans stated that the US doesn't have a responsibility to accept refugees in the country. However, it's not possible to generalize this finding to the country as a whole because these numbers fluctuate when political opinions are considered. For instance, studies show that Democrats are more likely to accept refugees and think that this is a responsibility of the US, while Republicans are more likely to be against. So that's why it's hard to generalize this finding. And that's why these differences imply that there are many factors that play a role on how people perceive outgroup members. It's not just black and white. So as I said, we used the AINS 2016 data set, which is publicly available on ICSPR, and this is the American National Election Study, which collects data 2 months before and after the elections in each election. And they have been collecting data on American social backgrounds, political dispositions, values, perceptions, evaluations, and opinions about groups, candidates, and ongoing discussions since 1948. And this is collected in each presidential election. And the particular data set that I used had a total sample size of 4,271 participants. And we selected specific items in this data set. This is a huge data set. There were lots of different questions, but we tried to select items based on 3 different categories that we want to find latent classes about. So the first one was refugees and Muslims, and the second one was immigrants, and the third one was minority. And we ran latent class analysis on RStudio with different number of classes and aimed to choose the best fit for the data relative to the model with one less class. And we tried to find the lowest Bayesian information criterion, BIC score, and because this was indicating the improved model fit, and that's why we used it as the primary indicator to decide the number of classes. So eventually our results showed that there were 4 class models and 5 class models, and these were the best fit models for our study because they had the lowest BIC scores when compared to others in their respective category. So these were the best fit models. For refugee Muslim items, we had 4 different classes, as you can see from the table. For immigrants, we had 5 different classes. For minority members, we had 4 different classes, and these were the BIC scores that we had for each one of them and the shares that they had in each category. So these results show that our attitudes toward refugees, immigrants, and other outgroup members in the US are more complex than simply being pro or anti-outgroup. There are variations, and there are 4 or 5 different categories we need to take into consideration while working about these perceptions. And our results show that there are 4 different categories of people on how they perceive Muslims, refugees, and immigrants, while there were 5 different latent classes about how they perceive immigrants. So that's why if we think that there are like pro-immigrants and anti-immigrants in the US and design intervention programs accordingly, that would be a wrong perception, and it wouldn't solve the problem because we will miss the gray areas that needs more focus because their ideas are more changeable than the anti-outgroup perceivers. And that's why these results shed light on potential latent classes by using a data-driven approach, and identified emerged classes and observed whether they look similar or not. And these findings also are significant because they challenge the idea of the outgroup homogeneity effect, because we think that all outgroups are the same and like there's homogeneity. However, there are different variations and nuances in each group. However, as always, there are some limitations with this study, and we will also provide some future directions. So our framework for understanding perceptions about outgroup members focuses on motivations between attitudes toward minorities, refugees, and immigrants. Attitudes towards this group are motivated by several factors such as security and economic concerns, as I mentioned in the beginning. So that's why we also included the item about terrorism as to see how it relates to so-called stereotypical image of a Muslim, to understand the role of security concerns in acceptance of Syrian refugees by the public. And future research should also include items about employment, because economic concerns and threat also plays a big role on people's perceptions, because there are some discourse going on about, especially about immigrants, such as they're stealing our jobs, or like because of them, the rents are increasing, and some statements like that are always heard all the time in different contexts. So that's why items about employment also should be included in this kind of a study to understand the economic concerns of Americans, because some prejudice are likely to be motivated by this competition for scarce resources. And also another point that is important is the biased sampling of the study, because it's hard to generalize the findings and say that they're representing Americans, because almost 71% of participants were white, and 9% of them were Black, and 10% of them were Hispanic. So that's why it's not a nationally representative sample, and it's difficult to generalize these findings to the whole American public. Thank you so much for listening to me.
Thank you so much, Merve. I think we're ready for our next presentation. And Dr. Saeed, would you mind going ahead? The screen's all yours.
Hello, everyone. Can you all see my screen here?
Yes.
Perfect. Okay. I want to first thank you all, especially the organizers of the Muslim Mental Health Conference, for having me here. I hope, given these times, that you and your loved ones are all healthy and well. And so I'm grateful to be here today. Today, I'm going to talk about a research project that focuses on refugee rights to health services and the political infrastructures that determine accessibility to these services. The Syrian refugee crisis is the backdrop of my research in Lebanon in particular. Due to the pandemic, I've been unable to go back to Lebanon to add and continue to this research. And in order to kind of start my presentation today, I will start with a conversation that inspired some of my initial research questions while doing ethnographic research in Lebanon in 2017, 2018. The story that I'll talk about is the story of Ahmed while visiting a friend in South Lebanon in 2017. I engaged in a conversation with a gentleman who was working on some construction on a friend's patio. In our exchange, it was revealed that he was a Syrian refugee and he had legally registered as a refugee with UNHCR, which is the United Nations High Commissioner for Refugees. I asked him if he had gone back to Syria at all after coming to Lebanon. He revealed that he had gone back to Syria to seek medical attention, particularly for severe abdominal pain that he was having. He said that seeing a doctor in Lebanon would cost him way too much, so he opted to go back to Syria instead. And given kind of the circumstances there as well, we can kind of see the complexities in that. So I asked him whether the journey was difficult, and he said that he had gone through various informal checkpoints, especially in Syria, but was able to pay people off along this journey which ultimately resulted in him spending roughly around $700 to be able to get a diagnosis on his abdominal pain, which amounted to additional cost. This conversation generated several questions, and these questions kind of helped in many ways to spur some of my conversations in terms of what this research would look like. And these questions really were focused on what rights do Syrian refugees have to health services in Lebanon, what types of services are covered, how, if any, did the status of the refugee determine their accessibility, why would Syrians jeopardize their safety and re-entrance into Lebanon, considering their refugee status, which restricts travel both within Lebanon, but also across national borders based on UNHCR regulations. And how do individuals like Ahmed challenge these restrictive regulations in hopes of seeking medical care? As we all know, 2021 marks nearly 10 years of the Syrian conflict that has had devastating effects on Syria. This has led to a population of 13.1 million roughly in need of humanitarian need, 6.6 million, the newest numbers, internally displaced in Syria, and roughly 5.6 million are refugees in neighboring countries, particularly in Turkey, Lebanon, Jordan, Egypt, and Iraq, with Turkey holding the largest population at 3.6 million. However, my research focuses on Lebanon, the country that holds the highest number of refugees per capita in the world. This means that 1 out of every 4 people in Lebanon is a displaced Syrian. In many towns where I conducted my research, this means that the Syrian population far outnumbered the local population. And this has ultimately led to a result kind of in one of the most kind of worst and most pressing humanitarian crisis in Lebanon at the time. A large part of it has to do with the infrastructural and social services that have been outstretched, financially unable to kind of meet the needs not only of the local population, but of also the Syrian population as well as various other refugee populations, particularly the Palestinian population, as well as populations from Iraq and Turkey and the Kurdish population as well. So the following talk that I will be giving here, titled "The Health and Humanitarian State of Syrian Refugees in Lebanon," is based on research and analysis during my field research in Lebanon. My work examines the impact the Syrian war has had, not only on Lebanon, but specifically in terms of the health and social ramifications of this displacement. The story of Ahmed and others direct this research project on how Syrian refugees negotiate social and health needs given their political status and how they go about doing so. My research reveals the making of a highly politicized and stratified administration of healthcare in Lebanon, and the complexities of obtaining healthcare and the limitations as well as the mechanisms used by Syrian refugees to maneuver within this very complicated system in order to seek services. What my research will show and will argue here today is that the administration of healthcare in Lebanon is highly politicized and stratified, creating many complexities and roadblocks in obtaining health services, even as refugees attempt to, and they do, maneuvering and pushing back against the Lebanese and UNHCR health system. And what my research based on the ethnographic as well as data collection reveals is that these restrictions are limited for a number of reasons, mostly due to the kind of the health costs, the complications of the healthcare system itself, the lack of knowledge of the referral process and obtaining kind of care as well, travel and documentation barriers and restrictions within these towns, and limited health coverage in terms of what is being covered and what is not being covered. So in order to really conduct this research, I use a mixed method approach that relies on both data analysis as well as ethnographic research. I examined both international and national organizations working on the ground in Lebanon to meet the social needs of Syrian refugees. I conduct research with several UN agencies and individuals in Lebanon. Particularly, I worked with UNHCR and UNDP, as they have been the primary institutions involved in the distribution of health aid and the politics of accessibility. I worked in particular at the UN headquarters in the capital of Beirut, but I also actually did most of my research in the regional office in the south of Lebanon, particularly Tyre. Here you can see it on the map. I also worked with a large local Lebanese NGO called SHIELD, the Social Humanitarian Environmental Intervention for Local Development. By working with and using the data analysis of these three organizations, I was able to chart the social dilemmas and political infrastructures that regulate the distribution of refugee needs. While generating this research, I was also kind of engaged in a public engagement on the ground through the organization of SHIELD, which works within these rural communities. On the other hand, I complemented this research with ethnographic research and interviews with roughly 40 Syrian refugees, such as Ahmed during my initial research inquiry. I focused particularly on 6 towns in the southern part of Lebanon, Bint Jbal, Yarun, Haditha, Marj Ayun, Wazana, and Marj al-Khakh, where my interlocutors ranged from Syrians living in small towns, paying for small apartments and residential housing, to Syrians living in informal settlements. My interviews serve as a way to kind of assess what average Syrians experience in seeking health services in their everyday lives. So coupled with the research with the international and NGO organizations that are distributing these health needs. Very quickly, the context I really focus on is South Lebanon in particular. This has been the site of my previous research, but for this particular project, it served many purposes. It's important in many ways. This 3,000 square kilometer area is outside of the capital and outside of major kind of international distribution organization. The south of Lebanon is considered also one of the most rural, remote, and peripheral areas in Lebanon, so somewhat understudied. Due to kind of this remoteness, there's also a lack of UN, or at least limitations in UN aid agencies working on the ground. And so there's a heavy reliance on host communities and local NGOs such as SHIELD to meet the refugee needs. I worked, as I mentioned, in the UNHCR regional office. There are 5 of them, but the one in Tyre in South Lebanon can be roughly 35 to 45 minutes away from some of these rural villages. One other really important factor in this particular area is that the Syrian population far outnumber the local population, which kind of also further complicated the communal dynamics that were there. So roughly at times, the local population was around 400,000, where the Syrian population was as high as 250,000 in this particular area. There are also some sectarian complications that exist as well. The southern part is predominantly Shia Muslim, and hence the involvement of political parties like Hezbollah and the Syrian conflict also created kind of an interesting understanding of the communal dynamics that exist here and the ways in which they determine kind of accessibility. So focusing on South Lebanon really produces a much more comprehensive understanding of refugee politics in the peripheries to better understand kind of these health concerns. I won't really be looking at the kind of communal dynamics in this particular project, as this project really focuses on the health issues. So if anyone's interested in questions about that, I will be glad to answer them. At a glance, Lebanon has a population of roughly 4 million and hosts roughly 1.5 million Syrian refugees, some placing the number as high as 2 million. As I mentioned earlier, the world's highest rate of refugees per capita. There are close to 1.1 million registered Syrian refugees. So keep in mind, although the number is much higher, this means that there are many refugees, Syrians in Lebanon who are not actually registered with UNHCR. As of 2015, UNHCR has stopped registering Syrian refugees, and I'll return back to why this process has taken place a little bit later. However, UNHCR has been the prime institution in registering Syrian refugees and meeting their kind of immediate needs. So not being registered as a refugee has several repercussions, largely linked to the lack of access to health services, inability to travel across the country without being scrutinized by police, risks of being arrested. It also hinders registration of marriages and births, as well as educational enrollment for their children, financial assistance through a cash card program, as well as kind of job opportunities and protections. Currently, 73% of the Syrian population over the age of 15 are without legal refugee residency status, which once again, think about the complications that are involved there. Prior to the regulations that were changed in 2017, Syrians were also required to pay a renewal fee of $200 to maintain their refugee status, which also created another impediment in terms of maintaining their livelihood, as well as kind of their mobility. As you can see from the data, over 50% of children, 69% live below the poverty line, with 58% living in extreme poverty. particularly Palestinian refugees from Syria live among the most impoverished in Lebanon as well. Part of what here is an image of the research or the informal settlement of the Syrian refugees in the southern part of Lebanon, known as Majd al-Khakh. 34% of the Syrians live in informal settlements, paying for rent about $57, while others who live in residential housing will pay anywhere between $150 to $200 a month. 50% work in an informal labor market, mostly in construction, farming, and agricultural industries, so that these levels of impoverishment, accessibility to social services also speak to problems of political legitimacy and infrastructural inadequacies that exist in Lebanon. And I'll be talking about those in a moment. A large part of the infrastructural problems that exist in Lebanon date back prior to any of the refugee concerns and are embedded in a much longer history. The Syrian crisis has only generated more growing concerns of the inadequacies of this system itself. Part of what we see is that 13.1 billion in losses in Lebanon since 2012, according to the World Bank. It is a country that actually is also going towards near bankruptcy currently in a financial crash. As well as there's been a 50% increase in the utilization of Lebanese hospitals, with over 31% of the births in the hospitals being Syrian. Part of this is due to a very weak health infrastructure in Lebanon as well. There are many reasons for that. Part of it has to do with the Lebanese Civil War, which took place from 1975 to 1990. That had severe effects on Lebanon, but in particular for the healthcare system, there were several repercussions there as well. Before the outbreak of war, the Ministry of Health really provided various health services through regional health centers, including governmental offices, governmental hospitals. However, in the post-war period, what we begin to see is this operation, the governmental hospitals, halting, and rather the emergence of an expansion of a private healthcare system. This has led to a very weak public health sector, with many private run hospitals operating and seen as the preferred place of care for those who can really afford it. So given the already weak public health system, it has really been unable to meet the demands of Syrians. Moreover, the current system creates various roadblocks to access care for Syrian refugees that need it the most. This has resulted currently in the—
Quick reminder, 5 minutes left.
This has resulted in the construction of the Lebanese Crisis Response Plan, thank you, in 2014, which has been targeted to meet the most vulnerable population in Lebanon. The most vulnerable population with the Lebanese Crisis Response Plan has really expanded the target population. It seeks to provide services for those deemed most vulnerable, both Lebanese, Syrian, as well as Palestinian from Syria, who would receive services through this restructuring. As you can see, 3.2 million in roughly 251 localities are deemed to be vulnerable based on kind of human geographic and vulnerability of those individuals. And due to time, kind of you can see where the locations of where the most vulnerable populations have been deemed. Part of what I quickly want to address here is that this restructuring that took place and was initiated in 2014 began with the Lebanese Ministry of Social Affairs in collaboration with UN agencies and over 131 NGOs and agencies, reconfiguring the distribution of assistance. And as you can see here, the steering committee is coordinated by UNHCR and UNDP, as well as the Ministry of Social Affairs, and they designate how resources are being distributed. So for example, in terms of the health sector, funds are allocated to the Ministry of Public Health, who then distributes this to UNHCR and the World Health Organization. So there's kind of this trickle down effect before services and finances and resources actually meet the needs of the Syrian population. In lieu of time, very quickly, the sorts of services that have really been targeted through this program have really been primary healthcare needs. So acute medical care and preventative care, as well as a focus on reproductive care and maternal care, and very limited resources in terms of secondary and mental health care. Out of the various organizations that work with UNHCR, the Ministry of Social Affairs, There are 140 who provide services for refugees, registered refugees. And I'll return back to this registration and the importance of registration itself. Part of this restructuring has been successful. 72.7% of Syrians registered by UNHCR have received vaccinations. There's been various campaigns to allow for free vaccination, as well as maintaining kind of a polio-free country. However, despite this kind of aggressive campaign, there are various difficulties and inability to access these health services. And more of this has become more prevalent with the COVID-19 pandemic. In particular, what we see here is that despite the restructuring itself, UNHCR and UNDP cite that 28% of Syrians were unaware of free vaccination for their children under 12. 13% who needed primary health services were unable to obtain it. And part of the question, and this is where the ethnographic research has really shaped most of my findings, is really looking at the ways in which, what are some of the difficulties in terms of sustaining and obtaining these sorts of needs. And for most Syrians, they're really unaware of what healthcare they were entitled to and what sort of subsidized services they had access to. So in my conversations, access to care is based on this network of primary healthcare clinics, hospitals, and health outlets and dispensaries who work with UNHCR and UNDP, as well as the Lebanese government. So within this system, only clinics and hospitals contracted by UNHCR receive subsidies for health services to provide for Syrians. So many of the complexities had to do with knowledge of knowing which clinics are part of the UNHCR system, exposing levels of accessibility, particularly in these rural communities. One particular woman I spoke to spoke of spending $30 to take a cab to have her daughter checked by a doctor. This meant that she would not only have to cross several towns over to seek a doctor who was within this network, but this created not only financial burdens, but also physical burdens, as well as kind of questions about mobility. So hospitals or primary care centers are not always accessible in these rural villages. A large part of it also has to do with the fact that there are also limited sorts of primary healthcare centers that work within the system. So many of my interlocutors spoke of traveling 30 to 45 minutes to find a hospital within this network. And a large part of this also had to do with not only obtaining travel accessibility, but also many Syrians that I spoke to spoke of curfews that were informally implemented in these rural small communities. So these curfews also set up imposing that Syrians be indoors before sunset. There were also various checkpoints restricting and limiting where they can travel and what sorts of transportation they were able to obtain. Very quickly, most of the healthcare service, as I mentioned, has really focused on reproductive care as well as preventative care. And only 75 to 90% of approved cases are generally covered. This is after determination that this is necessary and that the individual is deemed to be most vulnerable and in a threatening life-threatening manner. So not only for many Syrians that I spoke to, they spoke of being required to submit a cash deposit or retention of their IDs or UNHCR registration before they can obtain any sort of care. So the possibility of losing your refugee ID as well as accessibility to certain services is quite frightening for many of my interlocutors as well. In lieu of time, I will skip some of the breakdown of the maternal care because I know I'm running out of time at this moment. Part of the problems that exist is the complexities that exist in the referral process and who you would need to contact first before getting initial approval. And so this is quite complicated, and it does look complicated because it is complicated in terms of how to actually get services for urgent cases that are needed. Part of what I want to kind of leave us with today is that the difficulties that exist really have to do with the fact that 70 to 90% of hospital fees are covered only depending on socioeconomic vulnerability of the refugees, as well as the cost of admittance. There's a lack of service for secondary and chronic health concerns. Many complained of hypertension, concerns over diabetes. So these services have limited access and coverage. 55% of refugees know that they have access to some sort of subsidized care. So you can see the lack of knowledge in terms of what sorts of care they're entitled to. The high financial costs were a pressing concern, the long referral process, as well as kind of the refugee status and sustaining your refugee status. I will not be able to kind of go into this, but it's a very complicated system in which one needs to maintain their registration, particularly after UNHCR has stopped officially registering Syrians as of 2015 due to internal pressures within Lebanon, concerning the high number of refugees within Lebanon, as well as kind of the political and financial instability that exists there. So very quickly, kind of the main takeaways and what my research has really shown is that the healthcare system produces and reproduces vulnerability. The hospitals themselves are highly politicized spaces. Part of what we see here in terms of the very structure of the humanitarian aid agencies itself is that it creates various obstacles as well as inequities. So that we see here is that the system itself has pre-existing systemic issues that are embedded in the Lebanese healthcare system, coupled by exclusionary refugee policies, the infrastructural inadequacies and political interests have really shaped the ways in which access to health services takes place. Despite efforts by international and local agencies, there are very shortcomings, particularly for those living in those rural communities, as we see in the various stories. The growing concerns over Syrian refugee conditions during COVID-19 pandemic have also revealed kind of the limited sources. So what we see here is that the growing political and economic unrest with the crash of the Lebanese currency has only made some of these issues more significant and more important. And so by conducting this research and these interviews and expanding on sites outside of the capital itself, we're able to really see the continuing difficulties in terms of accessing health services for Syrians living in Lebanon at the time. So thank you all.
Thank you very much. I know it was a lot of information and you really tried to push it to the end, but I appreciate you being conscious of our time because we have the next panel. And we're ready for Dr. Adam's presentation. Dr. Adam, you can go ahead and unmute yourself and I will spotlight you and share your video.
Assalamu alaikum again, and I apologize for the technical problems. And thank you so much for helping me sharing the PowerPoints. So my name is Balkozar Adam. I work with the University of Missouri, Columbia. Next slide, I do not have conflict of interest. And my objectives for today is to understand the mental health needs of Muslim refugee youth and to familiarize you with the use of DSM-5 culture formulation and culture formulation immigrant and refugee module, as well as to review promoting refugee mental health video. I would like to start by sharing a story of a refugee Muslim. This was an adolescent Somalian girl. Her family immigrated from Somalia 6 months earlier. She lived in a refugee camp for 3 years. She was referred by the school counselor for not eating, not sleeping, and not speaking for 3 days. She reportedly was aggressive at home, and at school she was yelling at boys. The school counselor reported that she has difficulty dealing with men. The family reported that there is personality change and she was hitting her siblings. The admitting physician described her as being odd and irregular. There was no report of physical or sexual abuse and symptoms, no report of symptoms of mania, depression, PTSD, or anxiety. I was consulted because I was a Muslim psychiatrist on the hospital. So when I want to talk to her, she would not talk to me, she would not look at me. She did not answer questions. I was able to connect with the family and discussed her struggle with mental illness. I visited her on the inpatient unit on a daily basis, and I later was able to see her on outpatient basis. She was able to trust me and discuss with me her anxiety and depression related to living at the refugee camp and how the kids at school here were making fun of her, and how living in a crowded home situation on the housing project was scary to her. At the end, she asked me, can she get eyeglasses like mine? So we were able to make good connection. Now moving to the factors related to migration that affect mental illness. So with this case, we saw how her experience with migration presented hardship for her. Usually before migration, refugee may be exposed to war, persecution, economic hardship. During migration, they may face life-threatening event and physical harm. After migration, they may struggle with poor living condition, social isolation, unemployment, and acculturation difficulties. Next slide. In reviewing the challenges faced by refugee, the National Child Traumatic Stress Network noted that this refugee also have protective factors. So they tend to be hard worker, they are resilient, they made it here, others did not. The Muslim family mostly supported their kids. The kids can start school shortly after they come to America. The Refugee Resettlement Program and other agencies provide them with service, and the Islamic Center welcome them. Community acceptance varies depending on their background. It's hoped that the new administration that stopped the Muslim ban and will welcome Muslim refugees. It was reported that Bosnian refugees were able to acculturate and assimilate easier because of their Eastern European background. Next slide. Muslim refugee youth are at high risk of emotional disturbance and mental illness. This is significant in teenagers who are struggling with identity development while adapting to the new culture. I've seen some of them, especially those who suffered trauma in their country and who live in unsafe housing, getting involved with drugs and criminal actions. Next slide, please. The mental stress is negatively affected by the extent of trauma they experience in their country, and leaving family behind, facing the trauma is also an added stress for the refugee. I had dealt with a 9-year-old girl with severe anxieties and worries about her grandmother who was left behind in the war zone. In addition, the challenges of acculturation, including learning new language and culture, poor living condition, discrimination and hostility, can lead to severe mental illness. I want to share with you a teen-age Muslim boy I treated who witnessed war crime and loss of close family member. He became clearly psychotic after watching on TV continued violent event happening in his country. Next slide, please. Refugee families have to navigate different needs. The family work closely with the refugee worker to find job, car, place that would be big enough for the different member of the refugee family. They focus on the basic needs. They usually don't focus on getting their eyes or blood pressure checked or addressing their mental health needs. I know many Muslim refugee families that are in bad need for dental care, but they postpone it. The parent try to make sure first that the kids have food on the table and roof over their heads. All these challenges contribute to the increased mental stress. Next slide, please. For refugee youth, beside the needs to learn a new language, they may be lacking basic education due to unrest in their home country or the length it took for the migration process. I had a 15-year-old Muslim refugee who last was in school in elementary school. He could not return back to school after a bomb destroyed his school building while he was there. Usually, mental health need is not a priority for refugee. They focus first on safety at home before other needs. Next slide, please. Some of the common psychiatric illness noted in refugee patients include PTSD, depression, anxiety, panic disorder, somatization, and this diagnosis varies depending on the population and their experiences. And the studies also varies in the report of PTSD from 50 to 90% in adolescent, and for major depression from 6 to 40% in adolescent. Next slide, please. Muslim refugee go through 12 long, exhausting steps from the time they apply till they arrive to the US. When they arrive here, many times they found that the resettlement resources may not be adequately prepared to address their culture and linguistic needs. They are used to go to see a doctor when they are sick. They might not understand the need to make an appointment, the difference between inpatient, outpatient, urgent care, or emergency room. Because of their experience at home, we often find them overutilizing emergency service. They have a different understanding of mental illness. I had once treated an Arab patient who suffered from PTSD. However, for him, he did not see this suffering to be a problem. He told me, "Adi" means no problem, since other had also the same problem. So why he should be struggling? Next slide. Stigma is a major barrier to mental health services. They are afraid of double discrimination, not only being Muslim, but also mentally ill. They are afraid of being called crazy or magnoon, which may reflect more of psychosis. Next slide, please. I would like for you to take a moment and reflect on this statement from a Muslim refugee researcher. So if we tell the refugee family that your child has mental illness, they may feel very sad. So consider using other terms like problem with adjustment or stress. Next slide, please. Now, moving on the culture formulation. Understanding the culture context of illness is important in the diagnosis, treatment, and management. Race, ethnicity, language, religion, customs, moral, immigration status, and gender are all part of culture. Union of all this affect how the patient see their diagnosis and their willingness to be treated. So culture can be a source of strength and increased resilience, or a barrier to care. Next slide, please. Culture formulation interview is an operationalized tool to help us determine the impact of culture, race, ethnicity, and religion on our patients. Next slide, please. DSM-4 introduced the outline of culture formulation in '94 as a way to assess information about the patient culture and its relationship with mental illness. DSM-4 updated the outline and introduced the culture formulation interview. Next slide, please. The revised outline for culture formulation called for assessment in 5 areas. First, culture identity of the individual, how the person identified themselves. Second, culture conceptualization of distress. Maybe they think it's evil eye, maybe possession by the devil, maybe black magic. There may be people that you know who blame bad things happening on evil eyes or black magic. Third thing is psychosocial stressor and culture feature of vulnerability and resilience. So refugee has support from their culture and from the religion, and they also have vulnerability because they are minority, they have language barrier, and they have discrimination. Fourth, culture feature of relationship between the individual and the clinician. The closest personal example I can give you is that I once treated an Arab patient who suffered of PTSD. I was trying to talk to him in Arabic. So I used an Egyptian dialect. I asked him if he cries easily in Arabic, in Egyptian dialect. I asked him, بتعيط. And for him, he said yes. And apparently, I did not know that in his culture, when they say بيعيط means like he gets mad easily, he is very irritable. So if I added easily crying as a symptoms, it could have affected my diagnosis. Then the last thing is an overall culture assessment. You gather all this information and get an overall assessment of the culture of the patient. Next slide, please. Culture formation interview is quickly becoming the most popular evidence-based tool for culture assessment. The idea is for the patient to voice his own narrative, and it can be used for all patients, not only for minority, and not when there is only a clear culture difference between the clinician and the patient. Next slide, please. It consists of three components. The core component is interview of the patient. Next slide, please. This component is consistent of 4 domains. The first domain is culture definition of the problem. How would you describe your problem? What troubles you the most about your problem? The second domain is culture perception of cause, context, and support. So you ask the patient, what do you think is happening? What do you think your family, your friend, and other people in your community think is causing you to have this problem? Do you feel supported by your family and your community? The third domain is culture factor that affects self-coping in the past and past help seeking. What did you do in the past to help yourself? And what help did you get for yourself? The fourth domain is culture factor that affect current help seeking. What do you think you need now? Maybe you think you want to talk to an imam. Maybe he think he needs an herb that is only present in his own country. Next slide, please. The second component is the informant interview, which help the clinician get a different perspective from people who are in the patient environment, like maybe social worker, maybe family, maybe friends, and it also helps the patient feel supported. The third one is the 12 supplementary modules, which go and ask more in-depth questions on different aspects of care. Next slide, please. This is the culture formulation interview immigrant and refugee module. So it asks more questions about the refugee background. How about what country did you come from? Who did you leave behind? Who did you came with? How was the situation before you came? What kind of losses did you suffered from? And how it is in your new life. Next slide, please. Now, next one, well, I think the video will come, next one. Yes, now I want to share with you a grant that I received from the ACAP. I was able to develop this video on promoting refugee mental health. It is also
5 more minutes.
great, it's only 3 minutes. So it is translated to 6 additional languages. So please let us try to see that.
I hid in the bathroom to avoid death. I evaded terrorists who wanted to recruit me as soldiers who tried to draft me. These groups killed those who resist them. I saw numerous dead bodies and went through a stream of funerals for relatives. One night, soldiers came to my home looking for anti-government sympathizers. With my father gone, I was the oldest male, and it was my job to keep my family alive. We went to a relative's home, but their home was burnt down. We were constantly in fear of death. I am a refugee. When I came to America, I was poor and treated unfairly because of who I am. I spoke no English. I felt numb and detached. I was in shock and denial. I had a hard time and thought, why did I live through this when so many did not? I found a job working at a fast food restaurant to help support my family. It took a while before we could get a car and health insurance. My family noticed that I began to skip school, but they did not see my depression and post-traumatic stress disorder at first. They wanted me to make a success of my new life. I thought there was a stigma towards mental health, which made me and my family afraid to seek help. Many fellow refugee workers urged me to seek treatment. They offered me rides to healthcare visits, and eventually, I accepted. It took me months to realize that it is okay to get help. I wish I had gone sooner because my life is so much better now that I'm working towards good mental health and a brighter future.
There is no shame in seeking help. Mental health issues are more common than cancer, heart disease, and diabetes. And in the United States, mental health care is a huge part of our healthcare world. If you think you or a loved one needs help, please don't wait. Ask your doctor for help finding a psychiatrist or a family therapist. Once you have a visit set up, please make sure to bring something that shows who you are, like a driver's license or a passport, as well as your health insurance card and other health records. A psychiatrist may prescribe medicine as part of your care. You can buy the medicine at a pharmacy or a drugstore. It is very important to use medicine exactly the way you are told, or other health issues could start. If you or a loved one has thoughts of harming themselves or others, that is an emergency. Please use a phone to dial 911 right away or call one of the suicide crisis hotlines. These calls are kept private, and they will help you figure out your next step. We want you to feel at ease when you talk to a psychiatrist or a therapist. They are there to make sure you and your loved ones adjust to your new life in the United States. You deserve to enjoy your new home and find success here. Welcome to Columbia, Missouri. We're so glad to have you.
We have 1 more minute.
Okay. To conclude, if you can have the last slide, if not, I will just talk about it. To conclude, how to implement and apply this principle in your practice. You need to learn about your patient culture and learn how they explain their illness. Familiarize yourself with the culture formulation interview. Review the modules online. How to get an interpreter. Engage your team in help identifying culture factors. Help the patient overcome the stigma, which is a major thing. Connect to community resources that may understand the special needs of Muslims. And this take time, so set achievable goal and be patient till you reach that. With that, I would like to thank you for listening, and I'll stop here.
Thank you so much, Dr. Adam.
Thank you.
Lots of real and heavy stuff, Dr. Abbasi. We need you to put it all synthesized for us. Up your screen is next.
Um, thank you all for all the amazing presentations. This has to be the most, this is a segment I look forward to always, and make sure that it's such an integral part of the conference. This issue is very close to my heart, but whenever I'm here listening to all these presentations from different perspectives, one thing really glaringly stands out is that we are still approaching this issue with Band-Aid solutions for a gaping wound. From Linda, things like 50% kids do not have literally a citizenship or identity, right? Then we see this problem in Jordan, Palestinians living for years without citizenship. Then we see situation getting worse in so many European countries and America, Merve's presentation. So it seems that everyone, it's like one thing I think I would like all of you to talk about is the stateless generation that we are not taking in account, like what's gonna happen with this generation, which doesn't identify with one country. Literally, don't have roots. And so one thing is that concerns me for our future concern that I have. And of course, not only being stateless, that means they don't have access to education, health services, and like Dr. Adam said, what about the mental health? So another thing, of course, is the way the system is set up, the UNHCR role in identifying and granting who is refugee and who's not. And then the fact that people don't understand is that even if you are granted, first of all, it's almost a 2-year screening process in some countries. And then also you are dependent. It's not that there is a system in place that where the resources are. It's like which country is going to accept you. So you can be put into a country you have no idea, have no cultural matching, no language matching. On the other hand, like the fact that Lebanon has highest number of refugees per capita. Just imagine a country that's still reeling from its own trauma of its own civil war, limited resources, and to have to deal with this. That's one thing that really stands out. Other thing is, so UNHCR do the screening and decides who becomes refugee, but most of the time the refugees have to pay their ticket and their first home, the money has to be paid back to UNHCR. So people are not aware that it's not a free ride. And then also when you come here, you are not placed in any healthy or prosperous social situation. You are put in places where already there is already like gang wars or like, really bad areas of the city are allotted for these refugees to settle in, which does not help their trauma. But the biggest thing as a mental health provider that really, really worries me is in all this process, mental health is not part of the screening. So they might get some physical health screenings and other stuff, but their mental health is pushed till they are in some country. And then it also then falls on some NGOs working with these refugees. So it just boggles my mind that being in Germany, Freiburg, where they had this really Germany at that point really stepped up and everybody was like, oh, they're so generous. But when I went to Freiburg, their concern was that you have 1 year to learn German language in order to get citizenship or be integrated, without taking in consideration like the trauma, and of course the cultural, definitely like the German providers were struggling that why the refugees are not allowing their girls to swim with the boys, or had no concept of religion, or did not even want to take religion in account, to include religion in any of their resettlement policies. So to me, this is such a multi-level complex problem that we are seeing, and it's not going away. It's growing. The refugee and people who are displaced are growing in numbers. So I just wanted to throw this question out to you, Linda. You have worked for the longest period with these issues. Dr. Balkozar is looking at it from mental health, and Merve, of course, the concern that we all have is, and another thing actually that stands out is no two refugees are equal. So the ethnographic lens that you bring in, that maybe somebody from Bosnia, because of skin color, might be accepted more, but then the fear of terrorism coming from a Muslim country puts you under a whole different level of, suspicion, the mistrust. So it just boggles my mind, and I'm looking at like maybe like any thought process. Like we know the problem is there, but do you think there is a way to have the solution implemented more systematically at different levels? I'll open it up to all of you. What do you think?
It is really a very difficult situation with refugees from everywhere. And we just can look at what's happening at the southern border now. And every day we hear about that. And we look at the Syrian that were crossing the Mediterranean and dying in the Mediterranean Sea. And this is a continuous problem. The important thing is that there's no one like executive order can solve this problem. We all have to try our best to bring to attention about these issues with the refugees in general, and Muslim too, about they struggle with lots of mental illnesses, and this is the last thing in their mind to think about. They wanted to just be safe. They went through a lot. So how can we bring it to the public, the people in authority, that they need extra help? Maybe like when they come, screening for mental illness, providing with support for mental illness when they need it, trying to educate also our Muslim imams about keeping an eye on this, as they can be struggling, the refugee in particular and the asylum seeker, and they might have different understanding of their illness. But if we have a collaboration with imams, they may be able to help them and guide them to get the help they need. So I am having hope that the new administration, who are more willing to have an open mind about refugee, might help refugee in general.
Yes, Linda.
I think in many ways, I mean, part of the issues that my research shows, and I think the rest of our research shows, is structural and systemic issues in terms of trying to ease that process. I think you mentioned the question of even statelessness. In one of my slides that I didn't get to, from 2011 to 2018, they've been roughly 160,000 Syrian children born in Lebanon, yet 60,000 continue to remain unregistered. So that creates all the difficulties, as you highlighted, and as some of the stories also highlight, the difficulties in not only accessing service, but no political representation, difficulties in obtaining financial services, educational service, mental health concerns. So all these layers start from a very young age, in which various kind of barriers and roadblocks are put in place that make it difficult to obtain any sort of care. So I think finding a way in which facilitating or making more accessible or more knowledgeable, more apparent the ways in which the system can work in their benefit as opposed to working against them would be helpful as well.
Yeah, I think that's something that stands out, that that different countries accept this population, but then set up all these roadblocks to their integration and growth. So it's like you bringing them in, but you're putting this like all the odds in front of them. Like it's like, how do you survive against all odds? Merve, in your presentation, it seems like, so we have to then kind of disaggregate the data, like from religious point of view, from cultural point of view, and skin color. I think all this is so complex, like to understand. So one thing is, of course, most of these countries, we know the problem is that these countries have limited resources. Even in America, we are seeing the COVID-19 impact, the political will of the administration, all that is going to impact this work. So any positive things that came out of your research?
I think Merve is not in the room right now, Dr. Abbasi.
Okay. So I guess, unfortunately for the listeners, we have more questions than answers here, but I do feel having these conversations is important, having discussions, conferences around it. And I know there is parallel work being done. It's not all that gloomy, but for right now, it is overwhelming. So with that, definitely we can open it up for questions now and continue the discussion.
If you have any questions, please put them in the chat and we will present it to the panel. Also, I will utilize this moment to let everyone know that this panel is sponsored by University of Michigan, Center for Middle Eastern Studies and North African Studies. They are our sponsors for this particular panel. And while we're waiting for questions to show up in the chat, I actually have one. Linda, for you. I am wondering what your operation kind of looks like with the 3,000 square kilometers and the way you're able to do interviews and data and the picture. Kind of walk us through what it is to be like there in the middle of that conflict, doing what you do. It's so incredible.
Thank you for the question. I think part of the position that I have is that I've done research in that area for quite some time. So in order to do kind of ethnographic research, I think there are long-standing established relationships that you create over time, which makes it easier. And I think it's very important that I linked up with a local NGO that really actually knows most of these families and communities. So by name, they know who the members are, what their needs are. That's kind of the personal relationship, although they don't have the most, I would say, power in terms of financial power or political power. They are the ones that are in many ways the go-to individuals for many of these Syrians living in the South. So working with someone who is trusted by this community, but then also aware of their circumstances was also helpful to kind of enter these spaces, because it's quite difficult in terms of in many ways also to create, acceptance, to create trust with individuals who are already placed in a very difficult situation, both in terms of their own native countries and then being displaced in another country. And so there's wariness as to what you are doing here. Will you be able to help them? How can they? So there are very kind of misconceptions as well as fears about your role as a researcher. But as I mentioned, it's an area where I've done my previous research in, so it's an area that I have I have a lot of ties to in terms of kind of familial ties as well. So it makes it, it has made it quite easier to build those relationships over time.
But I think keeping with the context of the conference on healing and self-care, how do you keep, like, you're dealing with this trauma? And I've had medical students who have gone and worked with refugee in these refugee camps, and they come back and it's so hard for them to adjust back to the mundane, normal life they have in America. And so how do you deal with this trauma of going there and then coming back, and kind of how do you process it?
It's always very difficult to see the conditions that people live in and the circumstances that they're under. And then at the same time, there's this also sense of their resilience, because they do push back against the system. They do create spaces where their spaces are limited. They find ways to obtain sorts of services. So on the one hand, it's disheartening, yet at the same time, you also see the resistance and agency of these individuals who are, despite being told that they don't have citizenship here, or don't have a political status, are imposing themselves on the space. And so in that sense, that creates some sort of hope, but also kind of reveals kind of this resilience that people and that the community itself has in terms of their own.
I think that is a beautiful message to keep in mind, that in the end, the human resilience, and especially when I still remember a student coming to me, a grad student coming to me with issues of attention deficit. And he's saying that he thinks he's ADD. And I'm like, but why were you not diagnosed so far, right? But then when I'm taking his history, he talks about how going to school, in undergrad, school in his own native country, he had to jump over dead bodies to get to school. And the numbing, the shutdown, the cognitive shutdown, that the dissociation, the disconnect, right? And now that's what is impacting his cognitive ability. But the way he was saying it's heartbreaking, but it is also, yes, potential of human mind, the possibility of having hope, against all odds. So, and then I think, Dr. Adam, what we see is you are trying to cultivate that.
Yeah.
And, amazing resources that you guys are creating. So my question is, are these resources being distributed in the rest of the country as well? Please.
Yes, it's available. It's available online. You can use it. There are people that are using them in their everyday life. We have a grant with St. Louis. We are looking at African migrant in St. Louis, and we are using this interviews to help them get to open up and talk about their experience. I was going to say a couple of things. One, there is a movie called Born in Syria. It talks about different children from Syria and how they moved to different countries in Europe and all the struggle that they went through and the mental issues that they are facing. I would like to say, please look at it if you have time. I think it's a great movie. The other thing is, you were mentioning about the medical student and his experience. I got a chance to go to Bosnia after the Bosnian War, and there was a little river. So people, in order to go to work, they have to cross that river. There's some bridges, just small bridges. And they were telling me how it is hard for them to cross that river because that's where the sniper will get them. When they were crossing, and they were talking to me about all these dead bodies on the streets, and it was really very, very disheartening to hear their stories. So with all this trauma that they go through, how they can get the support, especially if they feel like this is not a problem, we all went through it. So how can we help them understand that what they went through is not everybody's experience, and they need to take good care of themselves so they will not be scared. We have Bosnian friends here in Missouri, and when they were the 4th of July fireworks, they cannot be part of it because they are just bring the PTSD symptoms.
Yeah. So I think one last thing, which has become a very big reality of our everyday's life, is on top of all this work we are doing, but when some untoward incident happens involving a Muslim student, or something happens that, like a marathon bombing or something, then how do you kind of deal with that? Or, the recent shooting, how do you not let it impact your work? Because I think we are living in such a fragile times, and continuing to do this work, it is so hard not to be impacted by all that is happening out there.
We all, when we hear about bad news, we always pray, hope it is not a Muslim, all the time. So unfortunately, some people had abused the young people's brain and introduced them to wrong things in the name of Islam. And we need to educate these people that Islam is not asking people to hurt others. Islam is a religion of peace. So how can we support each other when there's something like this? Maybe talking about it with people that you trust, people that go through the same experience. Maybe when we have the masjid in the past, I don't know, in our place here, the masjid is not opened except for Friday prayer. Maybe people can discuss that and help themselves and help other people in the community learn that we need to do the right thing, and we are here for each other, and we are not going to support anybody who is abusing the name of Islam in doing the wrong things.
Yes, definitely we stand up and do that. But it's unfortunate that we, on one hand, we are creating trauma. On the other hand, we refuse to treat trauma. And on the third hand, that perpetuates trauma. So hurt men, right? And we see that in all cultures and all settings. This is the basic where I feel that we are doing a big disservice, that mental illnesses, if they are the leading cause, like more common, more prevalent, and then when you put it in minority settings and when you put it in more vulnerable setting, like a refugee setting, then not providing those resources, but then have to deal with the consequences of not intervening in time. So Linda, what's your perspective?
Although I don't necessarily work on the US context, I think in general, and in terms of when I speak to kind of Muslims or teach about Muslims in the US and refugee politics in general, I think another thing is not only to kind of not address kind of mental health concerns, but also to keep in mind, especially in like US discourse, that, you know, the actions of one individual don't determine and represent the actions of a whole community. And obviously there's a purpose behind that narrative here in the US to target particular communities, which is not the same case in which white shooters are presented as. So this is not seen as, you know, a problem in, you know, white masculine society. Whereas when it is a Muslim or when it is an Arab, it becomes a problem that it is the Muslim community or it's the refugee community. And so how do we push back against the narratives that are created about Muslims that speak to that, while also continuing to provide, I think, outreach for these communities and all communities in terms of mental health. I think mental health is something that is not only a problem in the Muslim community, but many minority communities in terms of accepting and being aware of and being willing to speak to kind of mental health concerns. So how do you create more knowledge about that, yet at the same time, make sure to also push back against the discourse that frames all Muslims as, you know, terrorist when one individual does something, and how do we kind of try to speak to that when we can. So I think those are some of the things that I always think of when speaking to some of those concerns, you know.
Well, I tried very hard to end on some positive note, and I think the positive note is that there is innate resilience. And the other positive note is that there are people like you all committed doing this great work. We wish you the more strength, and hopefully we continue to support and collaborate with each other. And again, thank you for all the amazing work. And thank you for sharing it with us today.
Thank you for having us here today.
Thank you for the opportunity, and best wishes to everybody.
Thank you very much. That's all the time we have. So we're getting ready to end our session. I do see a question here in the chat about mental health resources and programs in the community. We'd recommend we put it in the app, the Huva app, so that the resources can then stay with us rather than just being put here in the chat. With that, thank you one and all for coming. Thank you to our sponsors, especially the University of Michigan Center for Middle Eastern and North African Studies, to all the panelists and the attendees. See you guys over at our awards presentation ceremony back in track A. Thank you very much. Assalamu alaikum.
Alaikum salam.
Thank you.